Hello everyone, let's see exostosis. It is basically benign bony growth and the most common in maxillary is maxillary palatal tori. It is a bony overgrowth in the midline of the hard palate along the mid-palatine suture. Its incidence is 20 to 25% and it is more common in females. It is usually a functional response to mastication or superficial trauma, or it can be due to development or hereditary. So it is usually nodular. Indications for its removal: if it is of large size and it is causing difficulty in speech and mastication, or it is the overlying mucosa is ulcerated, or it is interfering with the denture construction. So, before starting with the surgical procedure, we first form a splint because after surgery we can't take impression. So, before surgery is started, we make a splint. How? We will take a impression by impression compound and then make a dental cast. And on that cast, we will remove the tori. So, we will remove the tori on the cast and make the splint on the cast. After making a splint, we will start with the surgical procedure. So, surgical technique: LA is given, that is bilateral greater palatine nerve block and nasopalatine nerve block. So, we give vertical incision, that is a anterior vertical releasing incision and a posterior vertical releasing incision. Then the flap is elevated. So flap is elevated and it is sutured. So this flap is sutured to the alveolar process so that it do not cause any interference. Then this tori is removed. If it is small, then we use a osteotome, and if it is large, then rotary micromotor is used. So we create grooves. Horizontal grooves as well as vertical grooves are created with the bi-beveled osteotome, and this tori is removed. Then this part has to be contoured and smoothed with a rotary micromotor or chisel and mallet, and irrigation is done. And because there was this hard bony prominence, so after its removal there will be excess soft tissue which will be left. So that excess soft tissue has also to be removed, and then we will suture this. Then the splint we created before the surgical procedure, it is inserted for 3 to 7 days and it acts as a pressure pack. And then denture is constructed after 3 to 6 weeks. The complications of this surgery can be hemorrhage, hematoma, oronasal communication, and wound dehiscence. Now let's see mandibular tori. It is usually seen on the lingual aspect on the premolar area above the malohyoid ridge, and it is usually bilateral. Its incidence is 5 to 10%. Its indications of removal and occurrence is usually same as maxillary tori. So the major difference between these two is the surgical procedure in this LA, in this inferior alveolar nerve block is given. And then incision for edentulous patient is at the crest of alveolar ridge above the premolar area. So in edentulous patient at the crest of alveolar ridge, the mandibular tori is usually more interfering in nature. Even for the dentulous patient, it interferes with speech, with mastication, even for dentulous patient. So in dentulous patient also it is preferred to remove. So in dentulous patient, the incision given is clavicular incision on the lingual aspect from the incisor up to premolar area. The complications can be hemorrhage, hematoma, wound dehiscence, and complications related to flora of mouth. Thank you. This was all. If you found this video helpful, do like and share.